Well, we're about to start the lecture. I hope students are here and can hear me well. I am Dr. Lifshitz, Associate Professor of Chair of Obstetrics, Gynecology and Perinatology #1. Today our lecture will be devoted to infectious diseases during pregnancy, obstetrical problems and infections, obviously as denoted on the screen, HIV and pregnancy, and as well we'll talk in the second part of our lesson. We will discuss different perinatal infections, so-called torch complex infections, and I hope you'll better understand infectology problems during pregnancy and in obstetrical patients. So we are starting. Human immunodeficiency virus, we call it HIV, is a blood-borne virus that typically transmitted via sexual intercourse or with drug users when they share needles, for example, and also as well mother-to-child transmission, also available way of transmission. So three main courses of transmission: sexual intercourse, drug paraphernalia, and mother-to-child transmission. Okay, well, I see somebody already joined us. Okay, and HIV disease is caused by infection, virus. Two types of virus, HIV-1 and HIV-2, which are related to retroviruses, Retroviridae family, lentivirus genus. You can see on the screen a microscopy of human immunodeficiency virus 1 variants. The problem of HIV is very well known, and probably you've heard so many information about it. In the United Nations program created for HIV and AIDS prevention, which estimated that approximately 37 million people worldwide, which is 1% of global population aged between 15 and 49 years, is infected by HIV. And what is bad, that 1.8 million people are newly infected. Mainly young women, especially in the developing countries, have high prevalence of HIV. For example, in sub-Saharan Africa, continue to remain a high risk for HIV, with roughly 25% of new infections occurring in women of aged 15 to 25 years old, and 64% of people living with HIV worldwide live in Africa, namely in sub-Saharan Africa. New HIV infection rates are declining globally, anyway, as a result of efforts of United Nations programs, different non-governmental organizations, as well as governments of different countries. They support, many of them support programs for HIV and AIDS prevention, and that helps slow down a little bit infection rate, HIV infection rate worldwide. New infections among children declined 47% since 2010 as coverage and using of antiretroviral therapy, ART. You need to remember this acronym. ART is an antiretroviral therapy which is provided to pregnant women, and this has helped to slow down number of children delivered newborns to be infected. In 2016, AIDS, which is a syndrome, disease, actually disease of which is caused by HIV, AIDS claimed 1 million lives. Unfortunately, 120 were children. 74% of new cases in women in the United States are contracted through sexual intercourse, heterosexual intercourse, and 23% of HIV infections via paraphernalia, drug paraphernalia, contaminated needles. And only 3%, thanks God, caused by maternal-to-child transmission. Nowadays, it's very, very rarely can be seen that people can be infected through the donated blood testing, because we test in all countries, all services which provide blood for blood transfusion, they test blood, donated blood. So this was eliminated as a source of infection nowadays. Let's talk about family planning and pregnancy planning and HIV infection. As I mentioned before, 74% of cases are because of sexual intercourse. So we need to discuss with patients contraceptive methods, which may also provide some protection against HIV. Anyway, preliminary data suggest that women with HIV may suffer from subfertility. We don't know exactly why, but observational studies, they show us this. In couples planning a pregnancy, where only the female is HIV infected, because in some families a woman can be infected and her spouse, her husband, is not infected. We call it discordant couple. Or vice versa, the woman can be healthy, but her husband, her partner, is HIV infected. It is also discordant couple. So in discordant couples where the female only is infected by HIV, assisted insemination with the partner's semen is the safest conception method for pregnancy. And we usually do it when antiretroviral therapy is already started and reached the maximum viral suppression rate. In couples where the male partner is infected with HIV, natural conception carries a risk, obviously, as a sexual transmission to the uninfected female, and its safe alternative option include adoption or sperm donation from a healthy partner, or we can use in vitro fertilization, which can reduce viral load because we clean out the sperm of infected male to almost undetectable level. For concordant couples where both partners are HIV infected and those patients sometimes want to conceive and have babies, both partners should attain maximum viral suppression with a specific anti-HIV drugs, and they should be screened and treated for genital tract infection before attempting pregnancy. All women who do not desire pregnancy should be referred to a family planning specialist regarding methods of contraception, which also can sometimes protect against HIV transmission. For those couples, by the way, hormonal contraception, hormonal pills is a method of choice, as well as long-term reversible contraceptive methods can be used, like IUDs, intrauterine devices can be used. And for those couples who do not want to have babies anymore, want to use permanent methods of contraception, tubal ligation or vasectomy for males is also can be considered. Pregnancy does not appear to influence the progression of HIV disease, and this is a good news. And pregnancy also does not affect the survival of patients infected with HIV, which is an important thing to know, that pregnancy itself does not have a risk for health of women who is already infected with HIV. It does not cause progression of HIV disease, and also doesn't affect survival rate of those patients. It's important to remember. Currently, unfortunately, no vaccine is available for HIV prevention. We know about this. And no treatment, definite treatment for HIV. So prevention of HIV infection is very important, is paramount importance for decreasing risk of the transmission of this disease. Anyway, women with HIV should be extensively consulted regarding the ability to decrease the risk of perinatal transmission with antiretroviral virus therapy. As I mentioned before, only 3–4% of cases transmission is related to mother to child, so-called vertical transmission. In women of reproductive age who are being treated with antiretroviral therapy, the potential for teratogenicity and possible adverse outcomes for mother and fetus should be also discussed. It's very important to remember. All infants exposed to HIV during pregnancy should receive ART for the first 4–6 weeks of life. ART should be initiated as soon as after delivery, and we will discuss later on about this. Molecular diagnostics for HIV infection should be performed in HIV-exposed infants during the first 48 hours of life before hospital discharge, and 2 weeks of age if they are breastfed or otherwise at high risk or have additional risk. Breastfed infants should also be tested at 4 to 8 weeks after breastfeeding has been stopped. What's important to remember for doctors, for any physician who is in charge of patients during pregnancy, that we need to take the initial history anamnesis. We need to assess the status of the patient with HIV disease. For example, we need to send blood for CD4, T cells count, viral load. We need to understand, you need to remember that we need to start antiretroviral medications, and because we want to reduce the perinatal transmission, vertical transmission. So we need to know at the beginning what is the patient level of viral load, the number of her CD4 cells. A careful medical and surgical anamnesis, gynecological history, high-risk habits as well. Previous obstetric history should be done at the first perinatal visit. women with HIV infection should be screened for current and past exposure to intimate partner violence and depression as well, and referral may be supportive, and mental health services, if indicated, should be provided. Knowledge of normal physiological changes of pregnancy, such as enlarged thyroid gland and systolic murmur, is important to differentiate from disease process. HIV infection can affect actually all body systems. We need to remember it. Although I mentioned before that HIV itself does not affect survival rate for HIV-infected pregnant women. HIV infection can influence any system of the body. We need to remember it. So I see many our students is online now. Well, all pregnant women should have their status evaluated for HIV. All pregnant in our countries and probably in your countries, it's mandatory. So it's necessary to know HIV serious status from the first visit to prenatal consultation. The most common screening test for HIV is ELISA, which see presence of antibodies and have very high sensitivity rate. A positive test is, should be proved by Western blot. It's a specific viral proteins which is separated by electrophoresis. But it's quite rare false positive. So if patient is positive by ELISA and proved by Western blot, viral load is determined by plasma, RNA copy number, copies per milliliter, which is needed to assess the risk of disease progression. The viral load is important for decision making regarding treatment, antiretroviral therapy, and even for delivery management. We'll talk about it later. If viral load is detected, we need to start antiretroviral therapy, but we need also know the drug resistance for those patients, which is HIV infected. So we need to know HIV genotype. Not in all countries it's done, but providers should not wait for the result and for availability of such tests and initiate the ART. But it's better of course, to know the drug resistance profile. With the proper therapy, viral load should be lowered by 1 log within the first month of treatment and become even non-detectable level within the 6 months after initiating treatment. The higher viral load, the longer decrease may take. The higher level of the virus in the blood, the longer time is to wait for the decrease. We need to remember it. So plus sometimes resistance can take place. If the viral load persists or even level of virus is increased during this treatment time, treatment failure must be considered, and we need to adjust the therapy. Unfortunately, HIV quite rare goes alone with such patient. They usually have some concomitant infections, other infections like, for example, hepatitis virus infection. So we need to test those patients, and in our country is mandatory to test for hepatitis B virus, hepatitis C virus, as well as HIV and syphilis also. So hepatitis B surface antigen testing is recommended. HIV-infected pregnant women screen for HBs antigen, we call it Australian antigen, and they should receive the vaccine series during pregnancy if they are negative. In case of acute HBV infections, the risk of vertical transmission also varies with the gestational age, with up to 90% risk of transmission to the baby if the infection occurs in the third trimester. So the later HBV infection occurs, the higher the risk of transmission of this infection to their offspring. Co-infection with HIV and hepatitis C is common also and range, according to different authors, up to 50% of cases. So every second patient can be co-infected with HIV and HCV, which we call HCV, we call slow killer. So the diagnosis of hepatitis C is confirmed by identification of the hepatitis C antibody by ELISA test. More specific tests like RNA testing for HCV by PCR, also available for in commercial laboratories, and blood can be sent for such investigation, evaluation. High maternal viral titers has been associated with increased risk of vertical transmission. So the higher the viral load of HCV, the higher the risk of vertical transmission to the baby. We don't need to forget about other opportunistic, so-called opportunistic infection assessment. Opportunistic infections and assessment for such infection, like pneumocystis, which called pneumonia, Mycobacterium avium complex, toxoplasmosis, cytomegaloviruses. We will discuss it in the second part of my presentation about this. So we need to remember it and to assess the risk of such concomitant infections in HIV pregnant women. Of course, other sexually transmitted diseases need to be kept in mind. Like I mentioned before, we have to check for not only for HIV our pregnant, but also for HCV, HBV, and syphilis. Thanks God, it's not very common in our country nowadays, but probably in your fair countries, maybe have still high numbers of patients may have this infection. Anyway, screening for syphilis in our country we do RW or RV testing and specific reactions for syphilis is important to know and to for prevention of congenital syphilis of the newborn. Vaginal speculum examination usually needed for detection or excluding gonorrhea and chlamydiosis, because those infections quite often go along with HIV infection in those patients. Don't forget about genital warts and precancerous changes in cervix and vulva in such patients, so we need to check, to test such patients for HPV, human papillomavirus, and it's not very infrequent. Don't forget about tuberculosis testing. We see that we know that many of our HIV patients, they from the lower socio-economic class, and sometimes they have tuberculosis. So please don't forget to TBC testing, especially in developing countries. It's important to remember tuberculosis skin testing is very obvious and very easy to do. Do PPD. If screening test is positive, purified protein diurate result is positive, Chest radiography, even for pregnant women, is necessary to do to exclude lung tuberculosis, pulmonary tuberculosis. Actually, the risk of harmful effect of X-ray for the newborn is very low. Could be neglected. What else? What other tests need to be done in HIV? Infected patient, pregnant woman. Actually, routine prenatal monitoring is necessary for such patients. So we need to provide screening, ultrasonography screening for those patients, as well as first trimester screening, which is very popular in many Western countries, and I hope in your countries is implemented already prenatal screening programs. So ultrasonography is necessary to prove that the baby is alive. Dating of very important. We need to predict the date of birth. Actually, potential heterogeneity of the drugs which is used for ART is important. So some patients may consider delaying starting treatment after the 12 weeks of pregnancy because not to harm for the baby, and we need to respect this thinking of our patients. In women who are severely ill, the risk and benefits of this delay must be outweighed. If women present in labor and didn't have prenatal testing before, in a maternity unit we need to have rapid test for HIV, and we need to offer it if a woman haven't been tested before. So rapid testing when she is admitted to the delivery ward in the maternity house should be done. The rapid HIV test is a blood or saliva based, and the results usually available within sometimes minutes. Rapid test is reported to have high negative predictive value, almost 100%, and be highly sensitive and specific as well. So it's very useful. Patients whose test is positive during labor, ELISA test should be done, and those patients should be treated and should be approached as a HIV positive. Also, you don't have so far Western blot analysis proved, and all your next steps should be done as patient infected with HIV. Anyway, I can tell you that any patients you don't know the serous status should be approached as potentially infected. Just remember it. Sometimes we don't know exactly the results of the test, and any patient, not only obstetrical patient, any patient, surgery patient, therapeutic patient, and of course obstetrical patient, if you don't know the serous status for HIV or HBV or HCV, you should think it can be infected, and protect yourself and protect other patients who is near. Complete HIV drug resistance testing before treatment is initiated except in women presenting after 20 weeks of pregnancy. You need to do CD4 cell count at the start of combinational antiretroviral therapy, CRT, and additional test for CD4 count should be done at time of delivery. For women who begin CRT during pregnancy, perform HIV viral load 2-4 weeks after starting, at least one time in every trimester, at 36 weeks and at time of the delivery. During pregnancy, CRT should be offered in all cases, maximum, just 100% of cases. And you need to continue CRT treatment for patients who are conceiving and have effective CRT regimen. And we need to counsel that those patients need to continue their treatment for all their lifelong time. All women should have started CRT by 24th weeks of pregnancy. All women should have started CRT at the end of the second trimester. If there is no resistance to the drugs and the regimen lowered or suppressed viral load, medication can be used again, but avoid drugs which have teratogenic potential or adverse maternal effects. Zidovudine is very well-known antiretroviral drug. Monotherapy with this zidovudine should only be used in women declining of combined ART with the viral load less than 10,000 RNA copies per milliliters and who will have a cesarean section. All women who have been untreated and present in labor, term labor, should given nevirapine 200 milligrams and start orally zidovudine or zidovudine 300 milligrams plus lamivudine 150 milligrams twice a day. All antiretroviral drugs, they can be fall into three main categories. The first category of the antiretroviral drugs is nucleoside or nucleotide analog reverse transcriptase inhibitors. So they inhibit reverse transcriptase. We call them NRTIs. Direct nucleoside or nucleotide analog reverse transcriptase inhibitors. The second group, the second category of the drugs are non-nucleoside inhibitors. We call them NNRTIs, non-nucleoside reverse transcriptase inhibitors. The third group is the protease inhibitors. So obviously they inhibit protease inside the virus. The mechanism of action with which antiviral drugs reduce perinatal transmission includes lowering maternal viral load. Anyway, those drugs can be potentially harmful for the baby. They can cross the placenta, and we need to outweigh the risk-benefit for patients. CRT regimen, usually including 2 NRTIs with either non-NRTI or 1 protease inhibitors. So this is the mainstream, I would say, of the treatment of any HIV pregnant women. The NRTIs, for example, didanosine or stevibudine, are generally well tolerated and cross the placenta with variable safety profile depending on the agent used, so they can be used easily in obstetric patients. Non-NRTI are approved in the United States. For example, it's delaverdine, efavirenz, etravirine, nevirapine, and rilpivirine. Nevirapine and efavirenz, they can cross the placenta, they may have teratogenic effect on the newborn, so they may have some adverse effects, and the efavirenz, they not used usually in our country for HIV treatment. Protease inhibitors do not cross the placenta easily, and no teratogenic effect is reported on animals or animal models. This is the table of such preparations, such medications, classes of the ART drugs, and you see here NRTIs, for example, tenofovir, emtricitabine, lamivudine, this preferred combination, abacavir plus lamivudine also is one of the preferred combination during pregnancy. You see here that non-NRTs usually not preferred during the pregnancy, only like alternative schema. As I mentioned before, efavirenz is not usually here recommended for HIV-infected pregnant. Protein inhibitors, atazanavir plus ritonavir, darunavir plus ritonavir, very often utilized for HIV treatment, and those boosters, we call them pharmacoenhancers, like ritonavir, we usually join the schema of treatment of such patients. Integrase inhibitors, one more class of the drug, raltegravir, also can be used in patients with infected with HIV, pregnant patients with HIV. Every effort should be made to continue ART regimen, ART schema on the schedule in the peripartum period as much as possible to provide maximum virologic effect and to minimize the chance of developing drug resistance. It's very important to develop drug resistance. All HIV-infected women with HIV RNA level more than 1,000 copies per milliliter or unknown HIV RNA who present in the delivery ward should be administered intravenously zidovudine during labor, in addition to their regular antepartum regimen, regardless of mode of delivery. So we need to give zidovudine to the pregnant patient whom we don't know their RNA level or their RNA level more than 1,000 copies per milliliters. We need to give to their CRT regimen. Also, we need to give zidovudine. Zidovudine is given IV at the dose 2 mg per kilogram. Usually 1 hour takes for the infusion, sorry. And if a patient is having planned cesarean delivery, IV infusion should begin 3 hours before the procedure. In patients attempting vaginal delivery, amniotomy, the breaking down of membranes in the setting of ART and virologic suppression is not associated with increased risk of transmission of the virus to the baby and can be performed as a standard obstetric patients for standard obstetrical indications in case of fully virological suppression. But in case of high viremia, high level of viruses, amniotomy routinely used is not recommended, as well as fetal scalp electrodes during delivery is not recommended. Operative delivery with vacuum or obstetrical forceps And episiotomy also generally is not recommended, usually not done for those patients, because we want to protect patients from transmission of the virus. Antepartum CRT regimen should be continued postpartum. However, decisions regarding continuation should be made in consultation with the patient and her HIV provider. We need to ask consultations to come and to discuss with them their regimen, what drugs to prolong or to stop. In cases where hepatitis co-infection exists, we need to check the liver function test in 2 or 4 weeks after the start of ART treatment, and monitor them regularly throughout the whole pregnancy and even postpartum. Usually we recommend tenofovir, emtricitabine or lamivudine for those patients. Hepatitis A virus vaccination is recommended after the first trimester. Continue postpartum CRT against HBV and HIV, as well as against HCV and HIV. Stop HCV therapy, which is ribavirin based, for all women who find out that they are pregnant. So if a woman pregnant and she was on ribavirin based HCV therapy, you need to stop this therapy and have consultation with hepatologist and infectionist, specialist in infectious diseases. Normal vaginal delivery can be recommended if the patient is on CRT and fully suppressed with HIV, regardless of HBV viral load. Use a combined screening test for fetal aneuploidies and non-invasive prenatal testing for those who at risk. Patients who is HIV infected, so no much difference with other patients who is not HIV infected. So please monitor for aneuploidies, fetal aneuploidies, according to routine obstetrical management. Although do not perform invasive prenatal diagnostic testing until HIV status is known. Invasive prenatal testing should be delayed until HIV viral load has been suppressed to less than 50 HIV RNA copies per milliliters. Delivery within 24 hours should occur in all cases of term pre-labor spontaneous rupture of membranes. So within 1 day of SROM, we need to deliver the lady with HIV. Intramuscular steroids, HIV viral load control, and discussion about delivery is recommended when premature rupture of membranes occur and happens before 34 weeks of pregnancy. It's very discussed topic, the method of delivery of HIV patients. Caesarean delivery before the onset of labor may prevent microtransfusion that obviously occurs when the uterus starts to contract. So avoiding vaginal delivery eliminates exposure to virus in the cervicovaginal canal, the secretions, and blood at the time of delivery. So the idea to do a caesarean section is very obvious. We don't want to. We want to prevent microtransfusions. In late 1990s, prospective cohort studies noted a decrease in mother-to-child transmission in women on zidovudine who underwent elective cesarean delivery compared with women who didn't take zidovudine prophylaxis. And transmission risk was decreased by 80% for women who had both an elective cesarean delivery and were taking antiretroviral therapy. Although planned vaginal delivery for patients with a plasma viral load less than 50 HIV RNA copies at 36 weeks of gestation, it can be done. Cesarean section is recommended, pre-labor cesarean section, before labor started, if a viral load more than 400 RNA copies at 36 weeks of pregnancy. But operative risk, which go along with cesarean delivery, may outweigh the potential benefit of reducing HIV transmission. So cesarean section still poses some risk for any pregnant woman, so we need to wait out the benefit of it and the risk of it, even for HIV prevention via vertical transmission. Updated American College of Obstetrician Gynecologists year 2000 says that women infected with HIV whose viral loads are greater than 1,000 copies per milliliter should be counseled regarding the potential benefit of scheduled cesarean delivery to reduce the risk of vertical transmission. However, data are insufficient to demonstrate a benefit for neonates or women with viral loads less than 1,000 copies per milliliter. In the HIV-infected group, morbidity and mortality were associated with infections and related immune function, with greatest risk being for women with CD4 count of less than 200 cells per milliliter. Because morbidity is increased in women infected with HIV, prophylactic antibiotics should be administered during C-section. Scheduled cesarean delivery should be discussed and recommended for all women with viral loads greater than 1,000 copies per milliliters, whether they take CRT or not. Postpartumly, we need to offer cabergoline, which is dopamine analogs inhibitors, to suppress lactation for those patients, because mainly they do not want to breastfeed. We recommend to abstain from breastfeeding for patients with HIV positive status. And we, as I mentioned before, recommend to continue CRT postpartum. And when you discharge patients from the maternity unit, you need to discuss contraception, contraceptive methods. If patient is addicted to drugs, we need to provide some information to or refer to their narcologist, and so on. And also, of course, don't forget about PAP test, which usually taken in 3 months after delivery. And if I mentioned before, we don't need to forget about infant health, which is born from HIV-infected person. So all HIV infants should receive zidovudine during the first 6 weeks of life. Different doses of zidovudine. For example, if baby was born prematurely and less than 30 weeks of gestation, the dose usually 2 mg per kilogram orally, twice daily. After the age 4 weeks, increase dose to 3 mg per kilogram twice daily. If baby was born prematurely but between 30 weeks and 35 weeks of pregnancy, the same 2 milligrams per kilogram of zidovudine twice a day, and in 2 weeks you can increase dose to the 3 milligram per kilogram. If baby was born after the 30 weeks of gestation, you can start zidovudine 4 milligram per kilogram twice daily, orally from the delivery. Additional prophylaxis with nevirapine is needed for HIV-exposed infants of women who didn't receive antepartum ART at the following weights and dosage as you can see on the screen. For lower birth weight, 8 milligram dose orally. For those who more than 2 kilograms, 12 milligram dose of nevirapine. This is all for HIV and obstetrical patients. I have to break for 10 minutes and we'll continue in 10 minutes with you. Have a break, please.